Good evening, everyone. I'm really delighted to welcome you to our patient town hall, Vaccine, Variance, and the Third Wave. We hope to answer your questions tonight. We've got a great panel up, and I want to just begin, though, by acknowledging the land in which we gather. If we could have the next slide. We want to acknowledge the land on which we gather, that for thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. Next slide. I always find the land acknowledgement to be a great time to reflect on injustices perpetrated towards Indigenous people and our path towards reconciliation. And of course, that path includes more self-determination and more healthcare services delivered by Indigenous people for Indigenous people. And it's just great to see that happening in our own team. You see this picture of our Dr. Janet Smiley, Dr. Suzanne Schuss, and other team members who've started an Indigenous-led testing and now vaccination center, which is wonderful to see. Next slide. So I'm Dr. Tara Karen. I'm a family doctor at the Health Center for AD Bond, and I'm going to be your moderator today. And I'm really delighted to welcome you together with a great panelist, a great set of panelists that we have. I'm going to turn it over to them one at a time just to introduce themselves. So Brenda, can I turn it over to you?
Good evening, everyone. So my name is Brenda Chang, and I'm a clinical pharmacist at our family health team. I cover two of the clinics, the 80 Bond Health Center and the 61 Queen Family Practice Clinic. And for some of you who joined the first town hall, you may remember me. I was also part of the very first town hall.
Gord.
Hi, I'm Dr. Gord Arbus. I work at formerly what was called 410 Sherburne. Now we've recently moved to a beautiful site called Wellesley St. Jamestown Health Center at 95 Homewood. So you may end up seeing us there on call on the weekend for clinics, or if you're a patient at the clinic, hope you get there soon. It's a beautiful site. Thank you.
Thanks, Lee.
Hi, everyone. My name is Lee Schofield. I work at our St. Lawrence Health Center site down near the Market and the Esplanade, and I do low-risk family obstetrics in our department as well.
And Yulia.
Hi, everybody. I'm one of the family doctors at the 61 Queen Family Practice Unit. For my patients who might be out there, yes, it's me. I have rebranded myself a little bit. It's Yulia, Y-U-L-I-Y-A, but it's me. I'm really looking forward to tonight and hoping we get to answer lots and lots of the great questions that are coming in.
Thanks, Julia. Next slide. Of course, there's also a lot of people behind the scenes. I just want to thank who's made this possible. So our patient and family engagement specialist, who's active on the chat already, Nassim Zahidi, Anna Gadget, who is from our communications department at Unity Health, and Mark Kanek, who you're going to hear me speaking to throughout this, because he's the IT person behind everything we're doing tonight. So we couldn't have done it without this team of supporters. Next slide. I do want to also mention, that we are obviously going to be talking a lot about vaccines today, and it's really important for you to know that none of us today who are speaking have any relationships with pharmaceutical companies who are manufacturing COVID-19 vaccines. Next slide. So what's on tap for tonight? I already saw that question coming into the chat. So we have a little bit of a mix. We have a little bit of a presentation to update you on some things, but a lot of what we're going to do is Q&A. So we're going to start with, just an update on where we are with the third wave and the new variants. We're going to talk about getting care at our family health team, just so you're, well aware and comfortable with how to do that and what services we're providing right now. We're then going to do a deeper dive into, vaccines and how you can get them. And then we're going to do some question and answer, and lots of question and answer, actually. Next slide. When you registered for the vaccine, you had when you registered for our webinar, you had the opportunity to submit questions, and so many of you did. So we took a look through all of the questions that you submitted, and we put together what we thought were sort of the top most common questions that people were asking. And so you can see these on the slides. And so these questions on the slides are ones that we're absolutely going to cover tonight, because we know that they're important to you. So you asked, you live in a hotspot, where can I get the vaccine? When will I get my second dose? I've already got my first one, but I don't know about the second one. Does everybody need to wait for 4 months for that second dose? Are vaccines effective against the new variant? Should I get the Astrazeneca, or should I wait for the Moderna or Pfizer? What can I do now that I have the vaccine? Will it actually reduce the chance of transmitting the disease to others? What are my chances of getting the virus after I've been vaccinating? Can I mix and match? Will that ever become an option? Can people with immune deficiencies get the vaccine, or how about people who were pregnant and breastfeeding? So we're going to definitely cover these topics. So I want to assure you of that. Next question, next slide. But I know that there's going to be other questions that are rising, because just even in the week that's passed since you registered for this webinar, so much has happened. So please do continue to ask questions during this webinar. So how can you do that? We would ask you to put your questions in the Q&A. So that's the best way to get your questions answered. So go to the Q&A box and put them in the Q&A. And if you see a question in the Q&A that you have as well, that somebody else posted that you really like, because you want to answer that question answered too, please put a thumbs up. Because what's going to happen, we've got hundreds of people on this call tonight. And so we're going to prioritize the questions that get the most thumbs up. So if you like a question, give it a thumbs up. And that's why we encourage you to put your question in the Q&A. You can, of course, still use the chat to put out some remarks, and Nasim's going to send out some links in the chat all throughout the session. So yeah, keep an eye on the chat if that's your thing. I think it's a great place to network. But if you have questions, please put them in the Q&A. And I'm just going to remind people of that as we go forward. Next slide. So I also want to remind people of just some ground rules. Of course, this is a public forum. We're recording the session, so please share mindfully. You know, this is not a place for you to probably ask about your very specific medical questions. If you have a very specific health question, please book an appointment with your doctor, your nurse practitioner, your nurse. We'd love to answer them on a one-on-one basis, but no, try not to put those ones in the Q&A or the chat. Of course, use respectful language. We don't tolerate any kind of bullying or harassment during this call. We are on the webinar using closed captioning, and so we hope that we want to make this as accessible as possible. And if there's further things that we can do to make it accessible, we're going to send out an evaluation after tonight. And so please let us know what else we can do, and that's the kind of thing you can put in the chat as well. And then lastly, I just want to say that this is, a tricky time for a lot of us. We are all very stressed and anxious. There's a lot going on, and we as a team are here to support you. So emotions are riding high. Just remember that we all just have to be kind to each other, and we're here as your team to support you. Next slide. So I'm going to start out with just discussing a little bit about the third wave and where we at right now. Next slide. So this is a slide just from today that shows the number of COVID cases in red and the number of new deaths in blue. And unfortunately, we can see that we had this huge peak in cases just a few weeks ago. But luckily, that does seem like it was a peak, and that peak is hopefully coming down. Unfortunately, we do see that deaths are rising, and I'm hoping that those have plateaued. So we've been in a really dark place in our province, and my hope is that we're coming out of that. Next slide. We know that part of the reason this wave has been so deadly is because of new variants. So new variants of COVID-19 transmit faster, and right now they're actually responsible for more than 90% of the cases. So you can see that orange here on the graph, that's the new variants, and you saw that there are very few of them in the earlier time period, but now almost all of the cases are the new variants, the orange, and almost all of the new variants are what we call the B117 or UK variant. Next slide. So what makes a variant a variant? So a variant viruses mutate all the time, but a variant concern comes along when the virus changes in a way that affects how it spreads, the severity of the disease it causes, whether vaccines are effective, and whether diagnostic tests work. And right now in Ontario, we predominantly have 3 variants, although the B117 UK variant is by far and away the biggest variant that we have here. And certainly, as I mentioned, we know that they do spread more easily, and they also do cause more severe disease, unfortunately. Next slide. So what we can see here on these slides is, these are for people who are into the details. This is a slide that shows the rate of transmission, or RT. And what we can see is, when RT is over 1, it means that any person with a virus can spread it to more than one person. And we always want it to be below 1, because that means that we can control it. And so what we see here is that over the same time period, we've got the early variants on the right, and in the orange, we've got the new variants of concern. And the same measures that were helping us to keep down the early variants are no longer working for the new variants. So we need tougher restrictions in order to keep the new variants down. So that's a little bit of the narrative of why we are where we are today. Next slide. I'm sharing with some of you may know that at 3 o'clock today, there was just an update from the Ontario Science Table by press conference, and I wanted to share a few of those slides with you. This one, I think really illustrates that the virus is causing more severe illness. We see a huge upswing in patients who are admitted to hospitals in the orange, and people in the ICUs in the red, and I know you're hearing about that in the news. What was nice to hear is that our hospital rates are now flattening. We think that ICU admissions may still continue to rise for a couple of weeks. I'm hoping that they will also be flattening if we keep it what we're doing. Next slide. These are the key findings that the Science Table presented today. And I guess I highlighted in red here what I think is really one of the take-home messages, that the efforts of Ontarians are making a difference. Cases are cresting at a very high level, but they're cresting. We, of course, now have to allow them to go all the way back down. So what we're doing right now is working. And of course, we know there's a lot of other things that need to be done. And one of those things is vaccination. And that's why we're having this town hall, to help you to feel confident to get the vaccine, because we know that's a way out of this. Next slide. So one thing just to remind ourselves, yourselves, is that while we're in this 3rd wave, we have to be really careful to maintain our public health measures. So that means, we need to take precautions to stay home as much as possible still. There is a stay-at-home order in effect, of course. We've got to maintain our physical distancing, 2 meters apart, wearing our masks, washing our hands. So just to continue to do these things, and I know Ontarians are doing them, and we need to continue. Next slide. I think the other thing just to remember is that it is important to get a COVID-19 test if you have symptoms, or if you've been in contact with someone who's tested positive. So testing, as you know, is free, and we've got a great testing center here at St. Michael's Hospital, and also at our sites at St. Joseph's as well. Next slide. So the other thing that we wanted to convey to you is all of this is going on right now. How is this impacting our clinic? And can you still, are we still open? I know patients are asking that question. So Gord, I wanted to turn it over to you to talk a little bit about that.
Absolutely. Thank you, Tara. I think the key message we want to deliver tonight is that we are open, and it's very important that people get their medical issues looked after, whether it's related to a COVID concern or if it's related to any of their health concerns that they've been having or new health concerns. So we are open, very much so. Next slide. And so we will speak with you on the phone generally first, with a phone visit, a virtual visit, or computer visit. And some of you may have already had experiences with your providers on the phone or on video. And if there's a need, we will definitely see you in person, and that will be determined with your provider and yourself. And it's really important that there are issues that sometimes we need to assess you in person. So for something like abdominal pain or chest pain, there's certain complaints that are difficult to navigate on the telephone, and we would encourage you to come in for a visit. And I know that I've had some of my patients who've been reluctant to come in to get care in person or go to the emergency room because of fears of getting COVID. But we're we take great precaution in making sure that everyone is physically distanced, everyone is wearing masks, we clean all the surfaces that we use, and you are safe in our settings, in our healthcare settings. Next slide. Also, we are open 24/7, so it's important for people to understand that we are available. We would like to see you if you want to be seen. We have on-call service 24/7, and we also have urgent care clinics, which is either by telephone or in person. So each night of the week from Monday to Thursday, we have evening hours after the general clinic hours, and then we're open on Saturday and Sunday from 9 to 4. And you can see on the slide, each of the clinics, each of the night is open. And so you can see listed there which clinics are open on which nights and which clinics are open on the weekend. And if it's in the middle of the night even, you can reach a resident physician who speaks with the staff physician to ensure that your healthcare needs are looked after, even if it's the middle of the night and you have a health concern. Next slide. And the other thing is, it's really important if you really are unwell, whether it's related to COVID, or if it's related to having a health concern like chest pain, that you can go to the emergency room. The emergency room is open and they are definitely available to look after your healthcare needs. And this is really important. I know I've had patients in the last year who unfortunately have suffered at home with a very severe illness because they thought that they shouldn't be going out and shouldn't be going to the hospital, or that they might not be welcome there at the hospital. So it's really important that people's health issues be looked after. And so if you have a severe complaint, it's important that you reach out and go to the emergency room if you're very sick. Next slide. And the other thing that we're having now is, if you have COVID-19, we're launching a new program called COVID Care at Home to help you recover safely at home. Please reach out to us if you are unwell or need any support at all. And that could be physically, if you're having physical symptoms, we will help you. And as well, if you're dealing with some emotional issues and the stress of having COVID or financial stress of having COVID, it's really important that we have a team of people that you know that are there for you to help in these situations.
Thanks so much, Gord. I know that, I always want to drive home that point that we are open, we're here to serve you, and no matter kind of what your concerns are, so if they're medical or even if they're social, if you're struggling at home making ends meet, we have the resources and supports to help you. So reach out to us, and we'd love to be able to be there to support. So we know, though, that the vaccines are one of our big ways out of this. And so everyone, it's so nice to see so much engagement from people who are eager to learn more about vaccines so that they can feel confident going out and getting them. Next slide. This is just updated data from, I don't know how many of you guys have used this site before, COVID-19 Tracker. It's got some great data about where we're at with vaccines in Canada, and you can look at Ontario very specifically. And according to COVID-19 Tracker, we've given more than 5 million doses of vaccine in Ontario to more than 31% of the population, which is amazing. So that's first doses to more than 31% of the population. Next slide. Ontario actually launched just this afternoon its updated vaccine plan. And it kind of gives some stats around where we're at. Wonderful to kind of see, for example, that 94% of long-term care residents are fully immunized now, that 84% of long-term care staff have received at least one dose. And what we also see, for example, is that 90% or more of 80-year-olds now have received one dose. So we're on our way, and things are looking good. Next slide. I think one of the biggest kind of pieces of news with this release this afternoon is that as of May 24th, anyone age 18 and over anywhere in the province seems like they will be eligible for a vaccination. So they've released sort of this timetable, which you can see here on the chart. They're prioritizing some hotspots, perhaps not as much as some of us would like, but they've put those priority there for a couple of weeks. And then they so slowly are going to put the age restrictions down. As of May 10th, it'll be age 40 plus who can book anywhere in the province. Then May 17th, it'll be 30 plus, and then May 24th, it'll be 18 plus. So a lot to look forward to, and this is thanks to, I think, a kind of the huge kind of burst of supply that's coming in. And so I'm very excited about this. You might be able to have seen some celebrities with this T-shirt on, because this is our shot. This is our shot, guys, in order to, you know, champion our way to better. So next slide. I know though that all of you are here because you're interested, you know, in learning more about the vaccines and knowing how to get one. And I will say that getting a vaccine in Toronto is a bit crazy making. It kind of like somebody posted this graphic on Twitter and it really grabbed me because I feel like this is how it feels like to help a patient book a vaccine. And we want to kind of make things as simple for you as possible and tell you how you can navigate it. So I'm going to turn it over to Dr. Lee Schofield, who can tell us more about who's eligible right now and how they can book a vaccine.
Great, thanks very much, Tara. So I wanted to highlight a couple of things because it can be quite confusing at the moment on where to access vaccines and where to get this information. There are 3 key websites that really everyone should be aware of. Those that for us in the Toronto area and through Unity Health. So the first one is Toronto Public Health. This has some information on where the vaccines that can be available and how to get them. You can also search by your postal code at that location, which will give you some options as to where to register for the vaccines. There is also a provincial booking site, which is covid19.ontariohealth.ca, which has a central portal and access to the clinics and vaccination locations that are in the city and the pharmacy websites for those that are providing vaccines. You can also call the number on the screen, which is 1-833-943-3900. And then specifically for in the Toronto region, the Toronto hospitals and our partners have come together a few weeks ago and developed a website, Vaccine-to.ca, which is for hospital specific vaccination bookings and at our partner locations. And the number there is 1-888-385-1910. Next slide. So this is our current hotspot list of postal codes in Toronto. It is extensive, it's quite long. Your postal code may or may not be on there. And that does have an effect on where you're able to make a booking. Next slide, please. So the first thing I wanted to talk about was those of us that live in the hotspot postal codes, because things are a little bit different if you're not in one of those areas. So currently, if you live in one of the postal codes identified and you're over the age of 45, right now you can book at the community clinics and the city clinics and hospital clinics that were listed before. So essentially you can go to those websites and you can book through the pharmacy, you could book through our Unity Health, the Toronto Vaccine-to.ca, and then as well, there are sometimes pop-up clinics that are happening in those areas, which I'll get to in a moment, that you're eligible to book for as well. If you're in a hotspot if you're in a hotspot postal code, but you're under the age of 45, so 18 to 44, at the moment, you're not eligible to book at our hospital-based clinics, but you can book in the community and when some of the pop-up clinics do come up. And then specifically, if you're an education worker, including childcare workers, you can call the number on the screen, and you can actually book that way. And it's my understanding is that it's not available online. So that can be if you're living or working in one of those hotspot postal codes. Next slide. So how do you find out about these pop-up clinics? I feel like you need concert ticket booking experience and some savvy to do this personally. But one of the websites and social media accounts that has been quite helpful in recent weeks is Vaccine Hunters. So that's vaccinehunters.ca, or on social media, Vax Hunters Can. And on here, there are regular updates as to clinics opening, pop-up clinics that might be taking place, information on how and when you can book for those, updates on pharmacy information and so forth. So even if you're not particularly social media or internet interested or savvy, that is one place that I would suggest that you go check out and follow if you're able to. Next slide. So if you are not living in a hotspot postal code, you still have access to vaccines, but the eligibility is a bit different. If you are over the age of 40, you're able to book at pharmacy locations for the Astrazeneca vaccination specifically. There are some primary care pilots as well taking place. For example, our family health team was one of those locations that had some Astrazeneca vaccine made available to us. If you're over 60 years old, you can book online or by phone at the city and the hospital-run clinics. So that would be specifically going to the City of Toronto or the vaccineto.ca website. If you are an Indigenous adult, you are also eligible to book online or by phone at the city and hospital-run clinics, or you can phone the number on the screen at 437-703-8703. And lastly, if you've been following in the news, we were fortunate to have pregnant adults included on the risk of high-risk patients, and you can call the number 1-833-943-3900. And we'll talk a little bit more about those shortly, but that's if you're under the age of 40 and you're not currently living in a hotspot postal code and you don't meet one of these other criteria, then at the moment you may not be eligible or available to book for a vaccine. Next slide. At present, as part of phase 2, certain medical conditions that have been deemed higher risk or highest risk currently can book through our hospital-based clinics as well. So the list is included here, including organ transplant recipients, stem cell transplants, neurological diseases that affect respiratory function, those of you that may be on medication that can cause a suppression of your immune system, those of you that may be pregnant, or have an intellectual or developmental disability for yourself or someone in your family, or decreased kidney function, essentially. Your caregiver can also be vaccinated in this case, and there may be a little bit of difference from one location to another within the hospitals, depending on their location, but that's a general overview of the list. Next slide. So
Thanks, Lee. I mean, this is like, yeah, this is I mean, it's very exciting. You know, I think it's so confusing. And at the same time, I do want to just highlight some of these like success stories of what our team is doing as well, because although, you know, it seems like it's, you know, these mass clinics, the hospital clinics, our team is very involved. We've got lots of our own staff and physicians helping out in different ways. And as Lee mentioned, we actually did have a wonderfully successful Astrazeneca pilot at our site. We've given about 700 doses of Astrazeneca to patients across all 6 sites. But unfortunately, that's all the doses we got. So, you know, most recently when we advertised the last set of doses we had, our spots filled up within 90 minutes. And let me tell you, we're asking for more. We want to be able to vaccinate in our clinics. We know you want to get it in our clinics. And unfortunately, it's a little unclear why we aren't getting it in our clinics. Be happy for you to make your voice heard as well, that you want your family doctor to vaccinate, because it's something that we've been fighting for and just haven't been able to get, and we know our patients want it. Next slide. But as we, you know, in addition to doing that kind of thing, we are also, for example, vaccinating in shelters. So many of us have been vaccinating in shelter, both shelter residents as well as staff. And this is a great picture of one of our teams going out to do that mobile vaccination. And I think as of today, there's already 30 shelters that have been visited by our team and had some successful vaccination. Next slide. Really exciting as well, as we know that there's some really vulnerable people out there who aren't able to make it into a clinic, and we've got these great teams that are going out and delivering vaccine to people who are homebound. This is a picture of our team just getting ready to do that with their coolers, driving around with their cars, giving vaccine to people in their homes. Next slide. And then lastly, I just wanted to share that, you know, all of this is so confusing. But if you need help, we're here for you. So you just call the main line and you press 8, and you'll get to speak with either Donna or Io, 2 of our fantastic clerical, who right there ready to help you navigate and find an appointment. And of course, if you have a very specific health concern or question, our doctors, nurses, nurse practitioners, our pharmacists, and others are there to answer those questions for you. So please, we take a team-based approach and we're available and here to help you. So just remember, call the main line, press 8, and that's a great photo there of Io and Donna. Next slide. So I know that I just wanted to acknowledge that we already have like 80 questions in the Q&A. You guys are on fire here. And thanks to our amazing panelists, we've already answered 14 by typing. So you can take a look at that answered little part there too and read what some of the answers are. And then there's quite a few of them that we're planning to address. So we're going to start off with what we know are some of the common ones, and then we're going to move to some of your really great, some of them are hard questions that you guys are asking. So I'm going to go to the next slide, and I'm going to turn it over pretty soon to Brenda Chang, who's going to take us through some of these questions. So we've answered this first one. Lee told us where we can get a vaccine if you live in a hotspot, but how about when can I get my second dose? So we know that there are a lot of people who have received their first dose. Sometimes you go to a clinic and they give you an appointment or a piece of paper for the second dose time. And sometimes people have gone and they haven't gotten that. And so I think there is a confusion about what is going to happen. And I think if you haven't gotten that second dose, you can expect that it will be approximately 16 weeks, not more, and that wherever you got that first dose, they're going to be obligated to contact you to tell you when that second dose appointment is. I think moving forward now, more and more places are giving that second dose appointment to avoid that confusion. But then the bigger question I think a lot of people have is, do I really need to wait 4 months? Like, can I get that second dose sooner? So I'm going to turn it over, next slide, to Brenda, who's going to answer that for us.
Great, thank you, Tara. And maybe just to follow up on what Tara had already discussed around the confusion of when you're going to get your second dose. I don't work in a community pharmacy, but I do have a lot of colleagues who do, and they did inform that some of these decisions are, up to their head office staff. Sometimes it's related to not knowing the vaccine supply that's coming into their stores, and so they're given different directions at different points in time, and this information changes. So if you receive a vaccine, let's say in a pharmacy, some pharmacies may be giving information about the second dose and others may not. And this is the reason, it's just that they're being told different things. So we're sort of all waiting for some clear direction as well. So please be patient. It is what Dr. Tarkaran has said, you will get it roughly around the 16-week period. And that may change depending on our supply availability as well. So getting to the question of why we are delaying the second dose, can I get the next slide, please? So this decision was mainly based out of a recommendation made by the National Advisory Committee on Immunizations. So this is a group of experts who provide us recommendations around vaccinations. And it is not specifically just for COVID-19 vaccinations, but for all vaccinations that we have available in Canada. And their recommendation, based on the information that they had, as well as the limited supply of vaccines that we have, is that it would be most beneficial to vaccinate as many people as quickly as possible by delaying that second dose by 4 months. So if you think about it, it would be ideal if we followed the recommendations that is in the product monograph of all the vaccines. So in some cases, so for the mRNA vaccines, it may be sooner, 3 weeks to 4 weeks time a month. But in that period, if we extended it by another 3 months, more people can receive that vaccine. So if, let's say, if you have a family member, or if you think about your parents, you would certainly want both of them to be vaccinated, and not just have one of them vaccinated and the other not vaccinated. Some of the decisions around this, decision around the 4-month period is also based on information that we know or has been shown. So one of the key things is that there is promising data from a single dose of the vaccine, and I'll talk a little bit about more on that in a second. The other piece is that we do have some good understanding of the duration of immunity from other vaccines. So not just the COVID-19 vaccines, but just our experience with other vaccines in general. We do have a good understanding of duration of immunity. So some of that decision is based on that. And again, like I said before, it is based also on the limited vaccine supply. So in terms of the evidence, I think a lot of you did ask when we sent out the invite initially, like, what is the evidence behind this decision? So some of the decision or the evidence behind it is related to the information we have from the clinical studies. So the original clinical studies did show that we have some good data after giving the first dose, roughly around 2 to 3 weeks afterwards. We saw vaccine protection or vaccine efficacy, somewhere between 70 to 90%. Now that's in a clinical study setting. So in the real world, now that we've given the vaccine to so many millions of people elsewhere, we've also collected data to show that after a single dose, that protection is roughly 60 to 80%. So it is actually fairly close to the vaccine efficacy that we're reporting for all of the vaccines. So it's a good sign. So that is why, this is one of the reasons why we're putting this recommendation out there. The other piece around our current understanding of the duration of immunity is that we know from other vaccines, like let's say hepatitis A or the HPV vaccine, there is generally good immune protection for 6 months after a first dose. And in most cases, for scheduling reasons and other reasons, sometimes for other vaccines, people can't come back at this desired time, right? So let's say the next vaccine is supposed to be 6 months and then they're not able to come in and it gets moved to 7 months or sometimes 8 months or even longer. Generally, we never repeat a vaccine series. And the main reason for that is we have really good immune memory. So after we get the second dose, even if it's delayed, we have evidence to show that our immune system will respond in the same way and that we'll still have good immunity. So that's one of the key reasons. So even with some degree of waning of immunity after a first dose, which could happen, our models sort of show us and predict for us that we will have overall better protection as a whole that way. Next slide, please. However, there are, of course, some exceptions, and we do know that for some people, some patients specifically, the immune response may not be as good compared to the other population, the general population. So for these people whom I've listed here, they're the main exceptions. So we would like them to follow the recommended dosing guidelines for the vaccines as much as possible and not follow the 4-month delay. And that includes anybody who is a transplant recipient, either solid organ or others. And then individuals who have a malignant hematological disorder or a solid tumor of some sort on active treatment. So you're on chemotherapy or other targeted therapies, but not specifically on hormonal therapy or just radiation therapy alone. So these are our main exceptions to the 4-month delay. Next slide,
Thanks
please.
so much, Brenda.
No problem.
So I know that was like a really big question that a lot of people have, and there's a few follow-ups that I'm going to get to as well. But before I do that, I also just want to mention some real life kind of stories too. So we know, for example, in the UK, they made the decision to delay the second dose for up to 12 weeks. And we see in the UK now that they're, sat together with a really tight restrictions have brought their cases way down. And so that's some really good real world evidence that helps us to have confidence in this strategy. I think another one is that in Quebec, I think in the long-term care homes, they did a one-dose strategy. And again, we see lots of coming down of the infections in Quebec. So these are really good real world evidence that this one dose is helping us to bring cases down.
Can I just,
go ahead, Gord.
I just wanted to add that the Astrazeneca vaccine, in fact, the evidence is showing that 12 weeks getting your second dose shows the best protection. So specifically AstraZeneca, the recommendation is to get your second dose no sooner than 12 weeks.
Yeah, thanks, Gord. Now, so Neil is asking here, though, that if second shots are delayed, what do you think may be the possibility of needing a third shot to ensure immunity? So really good question, Neil, and I think others have that question too about boosters. I wonder if anybody on our panel wants to tackle that.
Well, I think the third dose is an interesting question in that if the immunity wanes over time, I think that that might be the issue for wanting to have a third dose. And the other thing that the companies are looking at is the variants to see if there's going to be a need to overcome some of these variants that have developed. And that might be another rationale for requiring a booster dose. So I don't think we have all the evidence yet, but the suspicion is over time, there might be the need for a third dose.
Yeah, so I think we just have to wait and see. And also, it sounds like, you know, in some ways, some people are speculating it might become kind of like a flu shot that we have to get on an ongoing basis, but we don't really know at this time. Brenda, it sounds like maybe you wanted to add something.
Yeah, I was just going to add sort of the same thing, is that we certainly need a little bit more time to make those decisions, because with other vaccines as well, you know, sometimes we don't even have all the information, let's say the shingles vaccine and whether people need boosters of those. So we do need a little bit more time to see how effective these vaccines will be over a longer period of time. And if we see that the majority of people vaccinated are showing waning immunity, we will know better whether we need boosters and whether those vaccines will need to look slightly different to like cover the variants, etc.
So, I mean, I think this kind of leads us to another question that people have been asking is, you know, is it safe to have a second vaccine of a different brand than your first vaccine? So can we mix and match vaccines? So for example, you got Astrazeneca, can you then get Pfizer when it's available to you later?
Again, this is a great question, and I think it's frustrating for people because we don't have all the answers. And I don't think we have the evidence yet, although there's certain jurisdictions that are already doing this because of supply issues. So in Quebec, for example, you know, they've run into some issues with Moderna supply. And so if someone got a Moderna vaccine, they're talking about giving, and they're already doing it, I believe, they're providing Pfizer as your second dose. So my understanding is that if it's an mRNA vaccine like Moderna and Pfizer, probably you're going to keep it if you are going to mix within the same type of vaccine. And the question is, well, what about if I got my AstraZeneca vaccine and I didn't tolerate it well and I want to get one of the other vaccines, or vice versa? Would that be allowed? And right now, I don't think we have the evidence, unless, Brenda, you have some other information or others.
Yeah, I was just going to add sort of the same information to say right now our National Advisory Committee on Immunizations is recommending that people try to stay within the same kind of vaccine, so an mRNA to another mRNA if you are not able to get the same one, exactly the same one as before, or a viral vector and then another viral vector vaccine. But that information may change. In the UK, they are already doing a study called COMCOVE that looks at giving different kinds of vaccines, so mRNA and a viral vector vaccine. From a safety perspective, though, it is likely safe and not really an issue of safety. But whether that translates to better efficacy overall or better protection for you from getting COVID-19, that may be a little bit early for us to know. And that's why we have these studies to kind of tell us, you know, is it better for us to do this? Some of the reasons why we try to stick with the same type of vaccine is because even though the outcome of the vaccine is the same, like it's supposed to do the same thing and tell our body to make antibodies, the way that it's shown to our body is slightly different. So that's why at this time, it's not considered interchangeable. The only exception really is the AstraZeneca vaccine coming from the UK, and then the one coming from India, which the name is actually called Covishield, but they are exactly the same. So they are the same. And in the setting of an allergy or severe reaction, then that is the exception, like Dr. Gord Arbus has said. So in those cases, we wouldn't obviously give you the same vaccine again. So we would switch it. And it would be safe to consider that. Like it's not a problem if you had a reaction to an mRNA vaccine and we have to give you a viral vector, that would be fine.
Yeah, so just to reiterate, the studies are being done. And I think actually Nancy put something in the chat here that that the study results should be out in May. And I've actually heard some of the same thing from infectious disease specialists that we should be knowing actually pretty soon. And I think in particular, we know that, we know that right now get the shot that you can get, and that's the strategy that's what we recommend. And if you have reservations about that, absolutely talk to your family doctor, talk to your nurse practitioner or pharmacist. There are specifically some people who are thinking, people who got the Astrazeneca may be able to get a mRNA booster afterwards. And so those studies are being done. And I think that that's going to be coming out in the next couple of months. We'll have some answers there. Now, Nancy Beeman did ask a very difficult question here that I'm going to pose to our panelists, and we'll see who wants to answer this one. Since we're probably not receiving AstraZeneca from India in the foreseeable future, will someone who received AstraZeneca for their first shot possibly get a different shot, Pfizer, for their second one in the next few months?
I'll make an attempt. I think what will most likely happen is that you'll receive the AstraZeneca from UK rather than the India AstraZeneca vaccine equivalent, like I mentioned before. That would be probably the first option, and whether we would be able to give the Pfizer would be a different situation if we had data coming out of that UK study earlier, and our experts on immunization, the National Advisory Committee on Immunization, if they provide us guidance differently, certainly we could consider it. But my sense is right now, if we don't have the brand coming from India, we would use the other equivalent.
And so I'm going to move on to our next slide here, because our next slide deals with a common question that many people answered many people asked when they registered for the webinar. Are the vaccines effective against the variants? Maybe I'll turn this over to you, Brenda, to answer.
Okay, great. Can I have the next slide, please? Thank you. So Tar has already mentioned about our variants of a concern earlier in the presentation. So the key to know is that we do have different variants that are circulating in Ontario, the key one being the B117, originating from the UK. And we know that it is about 50% more infectious. The next one that is circulating is the B1351, which originated from South Africa. And we also know this to be about 50% more infectious. The additional information that we have about this variant is that vaccines may be less effective for this variant. We have some data that kind of highlights, one, that antibodies used against this variant may not be as effective. And two, we also have information that when we give these vaccines, the amount of neutralizing antibodies that we produce may be less compared to the original circulating coronavirus. So we have some of that information for this particular variant. And then for the P1 variant that originated in Brazil, we find that the properties of this variant is quite similar to the B1351. So what we do know is that certainly they are different from the original circulating or predominant one originally, and that they may affect us. But the good thing about the one that's mostly circulating in Canada now, or in Ontario now, being the B117, is that we haven't found information to show that it would be less effective. And in fact, most of our information shows that our vaccines are still equally effective. And we know that also based on the real world UK data that's out there, that the people vaccinated in UK are mostly responsive. More recently, there is this variant of interest from India, or originating from India, called the B1617, and we call it a double mutant for a reason. The main reason is because it has two key mutations that affect how it binds, and we find that these two mutations do affect how well they respond to antibodies. So in some ways, it may be a little bit more harder to manage, but at this time, it's still considered a variant of interest and not a variant of concern, because we don't have all the information to know whether it will evade all of our antibodies or bind more tightly to our human cells at this point. Next slide, please. So what we know right now in terms of the vaccines and the variant is that we don't actually have information to show, or evidence or studies to show, that the vaccines will not work for any of the variants. Most of what we do know, like I said before, is that our vaccines currently do have good protection against the UK variant. And what we know is some limited responses to antibodies or reduced amount of production of antibodies, but the amount produced may still give protection, but it just may be different from what we would expect for the other normal circulating coronavirus. So this is certainly what we know. Researchers are updating their vaccines and information and potentially looking at producing boosters to improve our immunity. So more information will come, but this is sort of the information that we know at this time.
Thank you, Brenda. I'm going to take it to a question that's come from the audience here. It's different from the variant. So Anna is asking, some of us are concerned specifically because this is a novel type of vaccine, the mRNA vaccine, and not traditional. Can you please provide evidence of long-term safety of prior mRNA vaccines? I think a lot of us who hesitate would change our minds if we saw long-term evidence that mRNA therapy was safe. I'm wondering who might want to tackle that question.
I can certainly answer a little bit.
Go for it, Brenda.
No worries. So the mRNA vaccines are a new technology for vaccines, but the technology itself is not all that new. So we have used mRNA technology for cancer therapy and in other areas. So, I can't speak to certainly the overall long-term safety just because these are certainly new vaccines for this disease. And, we've only had them for a certain period of time, but because of information that we have in their use for other conditions, like in cancer therapy, it is good for us to know that we have other information to show us that the likelihood of harm is low. The other key aspect of the mRNA vaccines, and with all vaccines really to think about, is that the vaccine is formulated or made in such a way that it shows our body how to make the spike protein, and our own body makes the spike protein using the material that is sent to us from the vaccine. And after that process is done, our own body has enzymes to get rid of the material from the vaccine. So it is removed. We don't maintain the material from the vaccine in our body long-term to have long-term side effects. So for the most part, when you feel the aches and pains initially from the vaccine, that's the response, our own body's response, our own immune response responding to the vaccine. It happens for the first few days, and then you'll notice they go away, right? Because we've already responded, we've built the antibodies, we've moved our white blood cells to kind of attack what we thought was the virus. And then that process is done, and then it's over with, and then all of it is gone. And so until we get exposed again, let's say to the real virus, unfortunately, then we will build antibodies and we will know how to attack it. But otherwise, we wouldn't be producing a lot more of these antibodies at the time. So overall, even from all the data that we have from other vaccines throughout time that we've used, we know that overall vaccines are very safe, and there's only very few that may not be that's safe for us or that we would be worried about. And those may be some of the live vaccines, but certainly we also have really good data for those vaccines as well.
Thank you. Next slide. So I think a lot of people are posting some questions about Astrazeneca, and I just wanted to turn to that. I guess just carrying on from the previous theme of variants in AstraZeneca, somebody posted here, it's been concluded that AstraZeneca is not effective against South African variants. South Africa discontinued its use. What happens if that variant spreads in Canada or the UK, where AstraZeneca is widely used? So a tough question, and I wonder who might want to answer that one. So, I mean, I will just start by saying from my own knowledge is that you're right, that the AstraZeneca doesn't seem to be as effective against the South African variant. And, I think right now we're lucky that the majority of the variant here is B.1.1.7. But I think as we spoke about prior, studies are underway around mixing and matching and studies are also underway around efficacy in the variants. So we should have answers to this. And I think what we're experiencing here is kind of real-time science. And I think that can make people really anxious because we don't have all the answers at the time that you're getting vaccine that you want to have. And but I know our scientists are working furiously to get those answers for you guys, for everyone. I don't know if anyone else wants to add to that.
Yeah, I mean, I agree. I think this also leads to the question of future need for boosters, and you know, all these companies are looking at you know, tinkering with their recipe, so to speak, to adjust their vaccines to address the issue of variants. Now, fortunately, in Canada, we don't have the South African variant to a large extent. I mean, obviously, the gross majority have been the B117, the UK variant. And you know, time will tell. There might be issues with new variants as time goes by. But for right now, I would tell my patients, take whatever vaccine you are offered at this moment in time, because they all work to do what is most important, and that is to prevent hospital admissions, ICU admissions, and death. And the Astrazeneca vaccine, a lot of patients are cautious about it, but it's very effective and very well tolerated for the most part. I mean, people will have individual issues and side effect issues, but it's generally extremely efficacious and safe.
Yeah, so Gord, I mean, that's a great segue to us just talking a little bit more deeply about AstraZeneca. So Nicole has asked here, there's been a substantial number of serious blood clots, particularly in the brain, linked to AstraZeneca and Johnson & Johnson vaccines. By now, analyses and research might have revealed common characteristics in those who suffered from these serious blood clots. What are these common characteristics of those at greater risk to experience serious blood clots? So that's one of the questions I think that our attendees have, and I think attendees do have just general questions about AstraZeneca as well, in light of all of the news. So maybe I'll turn it over again to you, Brenda, to just walk us through a little bit of the evidence and what's known, and then I'll turn it over to our panel to elaborate.
Great, thank you. Can I have the next slide, please? So I'll address the issue of these very rare blood clots that we're hearing about so much in the media. The original term for it was called Vaccine-Induced Pro-Thrombotic Thrombocytopenia, or VIPIT. And this term was sort of given in the European countries. You may have also heard of it differently called VIT. Or even TTS, like different, I don't know, in the medical profession, we like to give everything acronyms and different ways to call it, but essentially it is sort of all very similar, referring to the same thing. And the condition is that it is a vaccine-induced condition that leads to blood clotting, and then also at the same time leading to low platelet counts. And I want to highlight it is a very rare condition. The blood clots have been shown to occur in the brain, but also in other places that are more rare. So not our very typical blood clots that you would see, like the deep vein thrombosis or the pulmonary embolism that occur in the lungs. So they are occurring in different places and slightly different. We know from the information that we've gathered so far, originally mostly in the European countries, that they tend to occur more frequently in younger women, and they tend to occur roughly between 4 to 20 days after vaccine. And some experts are saying maybe closer to 5 days or more, and not as early as 4. And my data here may be a little bit outdated already, but the data I have for Canada up to April 16th was that we had 3 confirmed cases for about 1.1 million doses of the AstraZeneca vaccine that we had given. And in Europe, it's about 10 in a million for the incidence, and in the UK, it's 1 in a million. So, overall, the incidence is still very, very low, as you can see. Sometimes the concern is, if you already have a history of blood clots, or if you're already taking a blood thinner, does it mean you're not safe to receive this vaccine? And the answer is no. Our experts in thrombosis actually consider these to be very safe, and that you should still go for your vaccine. And if AstraZeneca is the one that is offered to you, you should be receiving this vaccine without any issue because it does not increase your overall risk of a blood clot. This type of blood clot is very rare and is actually an autoimmune kind of condition that occurs. So it doesn't occur in everyone, and people do not have the same risks. And I heard the question of whether we know more about characteristics. So as far as my understanding is, apart from it occurring a little bit more in younger patients and more in females, I haven't really heard of any specific conditions or risk factors for this condition. So I don't know if my colleagues know a little bit more, but we don't have a lot of information about that.
I would say that, Brenda, just the latest that I've heard is that it actually doesn't vary by age, the risk. And so that's what they thought initially, but a closer analysis is showing that it's not age related. And I don't think similarly gender related either. So that seemed to be a signal in the beginning. So it is something that's really evolving. And one thing that I'll just put out there is you know, it's actually a good news story that we've been able to pick this up. I mean, you can see how rare it is. We've got 3 and 1.1 million doses, but you know, we know of these incidents because our reporting systems are working. So I think this is a reason to have faith in our reporting systems. Or did you want to add here?
Yeah, the other thing, and this is really important, I think, is that a lot of times, you know, patients who've had blood clots before, whether it's the deep vein thrombosis in the leg or the pulmonary embolus, the clot to the lung, those are very scary events. And so patients will come and say, I'm not going to take something that's going to give me a blood clot. But it's really important to know that just because you had those things happen to you in the past does not increase the risk of this happening to you when you take this vaccine. And your hematologist or vascular doctor will agree and in saying that you should take this vaccine, and it has nothing to do, having had this in the past has nothing to do with this potential event happening.
Yeah, great point. So I'm just going to go to the next slide, and maybe I'll just speak to this. The next slide shows a little graphic that kind of helps people weigh the risks and benefits of taking the AstraZeneca vaccine. Now, this graphic does actually have to be updated. It was produced by a group in the UK, and it does need to be updated because, as I mentioned, I believe the harms are actually equivalent regardless of age, and that does not depict it here. But what you can see on the left-hand side is the benefit. And the benefit does vary with how much exposure you have to COVID. And so what I put on the graph here is for 100,000 people, it's showing the risk benefit for people who are at high exposure risk. So not all of you may be high exposure risk, but the reason I put high exposure risk there is because we're in Toronto right now, and there's a ton of COVID in Toronto, and these new variants mean that COVID is spreading really rapidly. So I think for a lot of people in Toronto, they are at high exposure risk. So especially if you're going out to work because you're an essential worker, if you're not able to shelter in place and home most of the time, then you're at high risk. And I would say that even if you are just going to the grocery store and coffee shop, I know, and I'm not sure my colleagues would say as well, like I've talked to many patients who tested positive for COVID and they didn't know where they got it from because these new variants now are so transmissible. And then what you can see here when it comes to the benefits is that it's very clear that if you're over 50, so the blue here is the number of ICU admissions due to COVID-19 that were prevented every 16 weeks with getting the AstraZeneca shot. And what you can see is that if you're over 50, you have a huge risk of having an ICU admission with COVID. And so the benefit of AstraZeneca is huge. And that benefit's still quite big for those who are 40 and over. Now, of course, as you get under 40, that your risk of having a serious reaction to COVID is less. And so perhaps the risk benefit calculation is a bit different. But even in this graph with, when we're looking at high exposure risk, the benefits outweigh the risk, it seems, in every scenario. So, it is worth thinking about the benefits and risk in your own situation. And if you have questions about this, you can definitely talk to your doctor. Next slide. I mean, I think it's also worth putting the benefits and risks in context. Now, I know, Brenda, you put this together, this slide, and so maybe I'll let you speak to this. But I know one thing that I often compare the risk to is I think one of my colleagues said this, is the risk of getting a serious blood clot with AstraZeneca is lower than your risk of getting into a car accident driving off highway in a typical year in Canada. So we have to compare it to risks, everyday risks that we may take that we don't actually even think about. Brenda, I don't know if you want to speak to this one.
Yeah, sure. So I just put together some information that I gathered from our Toronto Public Health site, as well as the Ontario Public Health sites, in terms of the numbers. So this, the numbers are, so the numbers on the left where I've put chance of COVID is based on positive case count of approximately 1,100 people for the 2.7 million people that live in Toronto. So that's a chance of like 1 in 2,500. And based on the death count of approximately 8,000 for total case count of 450,000 in Ontario as of April 26, the death rate is about approximately 1 in 56. So, you can see at this time, your chance of getting COVID-19 is definitely higher than getting the very rare case of this VIPIT type of blood clot that we mentioned for the AstraZeneca vaccine. So, it's just something to keep in mind, like what was said earlier. The risk is actually very small, and you do have a very high chance of COVID. And certainly it's good news that we're sort of seeing the plateauing in our third wave now. But again, just to remind everyone, all the vaccines are considered very effective for preventing hospitalizations and even death. So, your chances are very good in terms of protection overall with vaccination.
Thanks, Brenda. Next slide. I think the other thing to just remember is that we now know what to watch out for, and we now can treat the condition. And so if you do get the AstraZeneca vaccine, we'll go over this with you, but we just put it on the slide. There's some very key symptoms here that you need to watch out for within the first 20 days. And if you have these symptoms, if they're severe, of course, call 911. If they're mild and you're not sure, call us. And as Gord mentioned early on, we've got a 24/7 doctor on call system here. So even if it's the middle of the night, we're happy to hear from you and answer that question. Next slide. So I'm going to pause and change over. So I think while, Brenda, Gord, and I have been doing a lot of yammering here, I think Lee and Yulia have actually been answering a ton of questions in the Q&A. And maybe, Yulia, I'll just turn it to you. I know you've been answering a lot of questions in the Q&A. What are some of the things that are standing out to you that people are asking that you think we should highlight?
Thanks, Tara. First, I guess I just want to say that I think these are all great questions, and that's why we had tonight, because I think we're all sitting here and you can't help but think, I was just looking at a question right now that Taylor asked, isn't it dangerous to make our seniors over the age of 80 wait the full 16 weeks for the second dose, knowing that it's like we have all these messages, it's like we have all this data that say one thing, and then we have these like practical things that happen on the other hand, right? And people are trying to like put them together. The evidence says people that are immunosuppressed maybe don't mount as big of a reaction, as big of a response. And then you're also telling me you got to wait 16 weeks, but you're also telling me that it's important for everybody, for as many people to get their first dose. It's like there's a lot of ands, right? And I think that, I think there's a lot of like two truths that we got to hold at the same time, right? And I think there's also a real core concept here around risk that we need to talk about. And that is, what is the risk, like your personal risk, and what kind of risk are you comfortable with? There was a great question here that I thought I wanted to talk about. It was somebody who's taking care of their elderly parent who's 85 plus and has all these health conditions, and they've all gotten their first shot, okay? And they're saying, and this woman is saying, hey, I've been doing all the grocery shopping. I'm trying to protect my parents, my elderly parents. But my dad is saying, I just want to go shopping. It's probably like literally the highlight of his day, right? To go to the grocery store and go shopping. And she's like, we've all had one dose, is it okay for him to go grocery shopping? And you know what? As a physician, if that whole family was my patients, right? I would say, look, I think you have to weigh out a lot of factors here. Is there a scientific answer? I don't think there's a scientific answer there, but I think there's an answer that comes when you look at a whole family and what different things mean to each person, right? That dad who's literally been like locked in his home for the last, who knows, year, is maybe really suffering now from being isolated and in home, and maybe going to the grocery store would make him feel better and would actually probably boost his immune system. Like, and I also think he has the right to say, I want to take a small amount of risk by going to the grocery store today, because the wellness that I get from being at the grocery store and like picking out my own fruit for the day outweighs the small risk of COVID. And I think to a certain extent, I think people are allowed to say that, right? And so I just wanted to make that point that we all want to protect everybody. I get it. But I also think for, you know, capable individuals, they're also allowed to say what's important to them and what brings them wellness. Like, wellness is not just the avoidance of virus. Wellness is also about, you know, what are we doing that's going to strengthen our immune system? What are we going to do to like fight off this virus if it comes to us? What are we doing to support the people that can't stay at home and are working and not getting paid sick days? So I think that's a piece that I just wanted to like step back and kind of address. The other part that I wanted to address briefly was, I understand there's a lot of anxiety around, when am I getting my second shot? So you get one, you're like, okay, and what's the risk of having, because it's unknown. I get it, how there's a lot of people that have gotten one shot and don't know exactly when their second one is going to be, because they had it done at a pharmacy and they maybe didn't get their actual appointment, or they'll say, hey, you know what, my appointment is actually like when I look at it, when they count it out, they're like, wait, this is 4.5 weeks out, or this is 5 weeks out. And I'm not an immunologist, but the one thing I do want to put out there is that, you know, after your first shot, you can feel a real sense of protection, in the sense that you're very unlikely after one shot to end up in the ICU or die from COVID. That being said, you could still get COVID after one shot. I think we all read these stories, right? I had the vaccine and I got COVID. But the folks who do get COVID after having that one shot, they're sick, the type of sick that comes with, you know, with their stuffy nose and like some like mild to moderate symptoms, not severe symptoms. So I think that's a really important point. And also emphasizing the need to continue to wear the mask and do our social distancing and do all of those other things. So it's like, you got to hold these two things. Yes, I have a nice bit of protection, but yes, I still need to do all of the same measures that we've been doing. And then we're fatigued, man. We all have this like COVID fatigue, you and I, all of these panelists and every single person out there, right? And so, you know, we're going to do our best to answer these questions. And I think that, is it frustrating how the vaccine rollout has gone? Yes. Have there politically been, you know, issues with regard to how it's gone? Yes. But are we all like at this point, like doing our best to get these vaccines out fairly and, you know, to the folks that need them? You know, a real success story is our long-term care settings. Our long-term care settings, oh God, it was heartbreaking to watch that happen in the first wave. Am I right? It was heartbreaking to watch all of these folks in long-term care centers die from COVID. And we've seen, like, you know, there are these graphs that show like long-term care infections, and then after the vaccine, it's like the deaths and the morbidity, it's just like, it's so low. And it's like, wow. And you're right. It also felt, and that's great, but it also felt unfair where I saw so many folks that came into, you know, the vaccine clinics who were taking care of these really elderly people who were living in the community, and they weren't getting shots because they weren't in the long-term care facility, right? And so, have there been some parts that haven't felt fair? You betcha. But I think at some point, you know, we have a set number of vaccines and we've got to make some decisions. Do we always agree with them? No, but I think let's not waste our energy there and let's just get a vaccine, you know?
Thanks so much, Yulia, for that perspective. I know, Lee, you want to jump in there as well. And before I go to you, Lee, I'm just going to highlight this sort of tension that Yulia brought out, partly because I think there is sort of, again, there's an uncertainty around some of this that we're dealing with. And I think each person has to weigh the risks and benefits. Now, it's true that after one dose, you know, a lot of the studies are saying that, you know, your risk of hospitalization is going way down, way down. But that doesn't mean zero. I just want to be clear about that, because we have seen some ICU doctors sharing stories of people in the ICU with just one dose. So it can happen. But so it's important to hold, you know, the relief on the one hand, but also with continued protection. And we talked about the ways in which you can continue to protect yourself. And I will also say that, you know, I don't think we as Ontarians have been given very clear guidance on how to behave, and that guidance needs to come out. So I'm hoping that it will come out and be more clear soon. So Lee, I'm going to go to you next. If you wanted to highlight some of the things you've been answering. You guys have answered, I think, 63 questions, not just the two of you, but others as well. But yeah, what stood out to you, Lee?
I just wanted to add one point to Dr. Rackel's comments. And someone said this to me when they were, I was speaking with them on the phone about the vaccination, and it really hit home with me when they said that. And the vaccines that are available now are certainly exciting and giving people a sense of relief, but it's not the only solution to this issue. And it is one of the tools that we have. And I think Tara, you just said the same, is really highlighted the same point, that this is one piece of the puzzle to try and deal with this pandemic and what is going on, but we also need to remember the other things that we know do help, which include the physical distancing when possible, and masks, hand washing, etc. So I just wanted to highlight that, and it did, because I think that we also get a lot of information from our communities and from media and other countries where vaccinations are being rolled out, and we get the impression that people can socialize and have parties and not wear masks. And I think the reality of that is not really the case, although we are seeing a decrease in the cases. But if we rely simply on the tool of vaccination and not the other pieces we know help, that we won't have as good of a response.
I just wanted to also advocate for our patients and people who are essential workers who are out there on the front lines working day in and day out and are most vulnerable to getting COVID and not being protected from being able to isolate at home if we're asking them to isolate. So I know in Ontario, we've been pushing the government to have paid sick days, and they came through with a policy that, you know, will give 3 days, which I don't believe is based in science and is not adequate. So I think we need to continue to advocate for people who are having to go out and work and have no choice but to earn a wage, because that's also part of the problem. And even if we vaccinate, those people are less likely to get vaccinated as well because of access issues. So I think we continue, as physicians and other care providers and patients, you know, we all have a role to advocate on behalf of those people.
Thank you for that really important reminder, Gord. I know it's been so upsetting for so many of us to see you know, a segment of society who's been contributing so much during COVID seem to be not getting what they deserve, and they deserve better protection and vaccination. Lee, did you want to jump in on that again?
I just wanted to say that one positive piece with all of that is that I think we really have seen the power of advocacy and people working in our communities and provincially. The essential worker component certainly is I think challenging for many of us, and so many of you as patients and us as providers. But pregnancy as an example, you know, there was a lot of lobbying and advocacy going on from different groups to make vaccines available to those individuals, and we've seen that change happen recently. And I think that as groups we can do that to try and push for some of these other changes as well.
Thanks, Lee. So I wanted to make sure that we do talk a little bit more about, do vaccines reduce transmission? We've alluded a bit to that. Brenda, I wonder if you can go to the next slide. And I know, Brenda, I wonder if you could just speak briefly to a couple of the points that you had wanted to make here. I know, really important points.
Sure. I think the bottom line is that we do have some emerging evidence. Like initially, we didn't know if the vaccines were very good for reducing transmission, mainly because the studies that were done for a lot of these vaccines looked at the outcomes of people who had symptomatic COVID disease, meaning that they actually showed symptoms, and then we tested to see if they were positive or negative for COVID-19. And we didn't really just test all the people who were in the studies, regardless of symptoms. But we do now have more emerging information and data to show out of some of the places where we've given a lot of vaccines, like in the US and Israel, that overall we have some information to show that it does help to reduce transmission. And I've just put some numbers there, but bottom line is we do have some more information to showing that likely the vaccines are helping to reduce transmission. Next slide, please. So while there is emerging information about transmission, like I said, the original studies didn't look at that. Another key point is that it is still possible for a vaccinated person to become infected without showing symptoms and transmit the disease unknowingly. And one of the reasons for that is the vaccines are not 100% effective, and we all know that. So while it gives us really good protection, we don't know that everybody will be 100% protected. So it's still important at this time to follow all the public health measures that we have. Now, this information may change, and this may change mainly because, one, if majority of our population is vaccinated, the transmission will obviously be lower in the community, and we may see some changes to our guidance around our public health measures. But at this time, it's still a bit early, so we are still advising to follow all public health guidelines.
Thanks, Brenda. So, I think we can end the slides for now, Mark, and just go off slide for a brief period before we end, because I think there's just a few questions left that we want to make sure that we address. I know some people, when they signed up, they had questions about people who were pregnant and breastfeeding and whether it was safe to get the vaccine and what the evidence is. And I'm just going to turn it over to you, Lee, maybe to answer that.
Yeah, certainly. Thanks so much, Tara. I'm very happy to talk on this topic and try and answer some of the common questions that we see. I'm part of our low-risk obstetrics team that works within our family health team and does our deliveries at St. Michael's Hospital. So we find that we haven't get a lot of questions regarding vaccinations in pregnancy and breastfeeding. So, and again, I would echo what Brenda said before, in that the part of the hesitation with vaccinations in pregnancy and breastfeeding comes from the fact that the studies that have been done initially often exclude these groups from the study. So we don't always have great information. But we do have information on vaccines, on previous vaccines that have been administered, and if they are safe in when you are pregnant or breastfeeding. So currently the recommendation is that if you are not pregnant, but you are looking to try and get pregnant in the near future, if you are having the COVID vaccination, they recommend that you wait at least 28 days before trying to get pregnant. This comes again from the recommendations of our guiding bodies, based on the information that we do have. A lot of people have asked around the mRNA or the mRNA versus the viral vaccination options when you are pregnant. And very recently, the National Advisory Committee again has now recommended that these vaccinations are available for those people that are pregnant and are safe in pregnancy. And talking a bit before, to echo Julia's comment, a lot of these things again are balancing risk, a risk against benefit of having your vaccine. So being pregnant, for example, Astrazeneca, being pregnant itself puts you at an increased risk of clot, whether that's a DVT and pulmonary embolism. And, although those are different mechanisms than what is happening if you have the AstraZeneca vaccine, for example, the risk is much less than the risk of when you're pregnant specifically. At present, you are able to book, if you are pregnant, for a vaccination through our hospital and pop-up based clinics, which is through the Vaccine-to.ca website. The other piece of this comes to those individuals that may be breastfeeding or may be delivering soon, maybe in your third trimester. I will add also that these vaccines are deemed to be safe in all trimesters of pregnancy. So that is something that I would suggest you speak with your provider specifically about. But this week alone, we have been targeting the patients in our family health team at the hospital that are pregnant to try and offer them vaccine. When we look at newborns that have whose mother has had exposure to COVID-19, what we do know is that the antibodies to the virus are seen in the newborn. What effect this will have in terms of conferring immunity to the newborn, Part of that will depend on what we're watching with studies now and what the research will show, but we have seen that the antibodies do cross, and hopefully that will translate into protection against COVID as well. For those people that are breastfeeding, there's a couple of parts to this. So I would say last year, even over the last 14 months, we had a lot of patients that would deliver in the hospital that would want to try to breastfeed after delivery. And some of those patients would have COVID and be admitted to hospital. And there was a lot of fear around whether or not they could breastfeed or not. And we know that if you do have COVID-19 or symptoms, it is safe for you if you're using appropriate protection for yourself to breastfeed your infant. And we do know, again, that there are antibodies that cross through the breast milk, but this is all safe. And if you have the vaccination, it is the same situation, and it still continues to be safe for you to breastfeed.
Thanks so much, Lee, for that comprehensive kind of in-depth response about pregnancy and breastfeeding people. The other population that people wonder about are people who are immunocompromised. And someone actually posted very specifically, are immunocompromised individuals significantly less protected by the mRNA vaccines, especially in light of the newer variants? So someone was asking that question. I wonder, Gord, if you'd be interested in just speaking to about people who are immunocompromised.
Yeah, this is a really great question, and you know, there are different reasons why people will be immunocompromised. And the general principle is that in terms of safety of the vaccine, it will be safe to take the vaccine. It's just that you may not mount as strong an immune response if you have severe, immunocompromise. So, for example, if you have HIV and you have very low CD4 count or low immunity, you may not form as strong an antibody response. But in terms of the safety, there should not be concerns. Now, there are other states where someone has a compromised immune system where someone might be taking certain medications. So like monoclonal antibody treatment or checkpoint inhibitors, these are classes of medications, and Brenda could speak to this as well, that you may need to space the time that you get your vaccine from the last dose of those medications, and you may have to speak to your specialist about coordinating that. And Brenda, maybe you could speak about that specifically as well.
Yeah, sure. So like Gord said, it may depend on what kind of treatment you're on. Some of these treatments are not given that close together, like it may be every month or every 3 months. So certainly we can time the vaccines according to your schedule. I know it's a bit tricky because you may be getting an appointment, through a pharmacy or different places where they just give it to you and you may not know. So a lot of the decisions involving what to do with those treatments might depend on what your specialist will say. So if your condition is very stable, maybe it's okay to hold for this period of time. They would be able to direct you a little bit more, but it depends on a few things around, how long the medications last, and where you are at with your disease.
Thanks so much, Brenda and Gord. I think we have time for maybe a couple questions. Maybe we'll squeeze in a couple here. Nasreen is asking, which vaccine covers the double mutation from India? So really good question. We know it's really devastating what's occurring in India right now. It's heartbreaking. We're seeing those stories come out. What do we know about vaccination with that Indian variant? Brenda?
Maybe I'll start off by saying that we know that variant contains one mutation, the E484, and that's the same mutation that is in the South African variant. It does have a second variant, I believe it's the L452, I may have the numbers wrong, but that mutation is also found in some variants that originated from California. So I don't know very much about the second mutation, but certainly for the first mutation that I've highlighted that was also found in the B1351 or South African variant, we do know that that mutation itself lends the vaccine to be not as effective. So we do know that whether that excuse me, remains to be true over a long time. I'm not too sure, but that's sort of the initial information that we have. It does carry the same mutation as the South African one.
Thanks. And then Marlon's saying, if all vaccines are equal and good, why are certain vaccines being given to some population ages and other vaccines being given to other populations and ages? That's a really good question, Marlon. And I guess I would probably just jump in, and I'll get my panelists to jump in as well. But right now, I think the only, Health Canada approved the vaccines for, I believe, in general, 18 and over. And our national immunization body said for Astrazeneca, really at this time, Astrazeneca should only be used for those 30 and over for the reasons we talked about in terms of the risk benefit. And when we look at Canada as a whole, there are many parts of Canada, for example, that do have very low risk of COVID right now. So I don't think that there are a lot of differences in terms of the national recommendations. However, what's happening, I think, is that on the ground, AstraZeneca can be stored in the fridge, and so it's more available in pharmacies and primary care offices, whereas Pfizer and Moderna have some really strict storage and distribution requirements, and so it is easier for hospitals and city mass immunization clinics to hold those. And then so I think the whole thing about age eligibility gets confused related to kind of where we are able to have certain vaccines because of logistical issues. So that's sort of my take on that. And I wondered if anyone else wanted to jump in.
Yeah, Tara, the other thing I would add, I totally agree with what you're saying, is that we haven't talked tonight about the Johnson & Johnson vaccine. And this is another option that I think will be really interesting because it'll be one dose and it'll be really, I think, very useful for hard to reach populations, people who may not be able to get back for that second dose, or who are maybe living on the street or in isolated communities. And so I think that's another great option that can be used, and it's just one dose for now.
Thanks, Corey. So Mark, I'm wondering if you can just pull up our second last slide here. I just want to, I see we're at 8:32 p.m. now, and so we're just a little bit over. And I know we had at one point more than 400 participants on this town hall. We've received more than 140 questions, and I'm so pleased that we answered 89 of them, either live or through typing. Plus, we had lots of dialogue in the chat. So maybe we can just go to the next slide, Mark.
Can I add one comment just before you go to the end? Just specifically around just around children and vaccinations, just because there may be some
please go ahead
on the chat. So right now we do have people asking about the availability of vaccinations for children and adolescents. This is a little bit location specific. There are some locations right now that are offering children that have other complex medical conditions that have a higher risk of complications from COVID or complications of getting very ill from COVID, to make those vaccinations available to those individuals. So certainly we would suggest, if you have children in that situation, that you speak to your provider about it. Again, the studies initially did not include children under the age of 18, but there are studies now being done in adolescents and children on the effectiveness of the efficacy of these vaccinations. So I think you will see more information coming out, and likely they will also be deemed to be safe, but we just need to get some more information at this time.
Thanks so much, Lee. I forgot to get to that point about children, which is one of the questions that we said we'd answer. So thank you. Next slide, Mark. So, and we'll just go to the second last slide, Mark, if we can. Yeah, thank you. Oh, the last slide is fine, actually. So I just do want to say thank you. Thank you to our panelists, Brenda Chang, Gord Arbus, Lee Schofield, and Julia Raquel. I want to thank our back team, Anna Gajic and Mark Kanak and Nassim Vahidi. We couldn't have done this without our team. And as you know, we strive to provide excellent care to all of our patients. And we've got a really big team behind us that we're kind of speaking on behalf of. Thank you to all of you who joined. As I said, that there were more than 400 people who joined this at one point, and I know that many of you are probably keen to see some of the, to perhaps watch some of this video again or to share it with others. And rest assured, we're going to make the recording available. It'll be available on our family practice website, and we will also email it out. You know, if you know others who want to be on our email list, please do ask them to call our front desk and leave their email address, because that is often how we're now communicating in an efficient manner with patients. We also want to hear from you, your suggestions. So this is only the second patient town hall that we've run. Following the session, we're going to share with you an evaluation. We just ask you to tell us your honest opinion. How did you like it? But also importantly, do you want to have this session again? And if you do want to have it again, what topic do you want to hear about? So we really want to get your input in terms of designing these sessions for the future. So thank you so much for attending today. Thank you to our panelists and our team, and stay safe and stay well.